The WHO actually has got something they call it the Toolkit for delivering the 5 RAs and 5 Rs brief tobacco interventions in primary care. And I will send that round as well. It's a very nice guide that's got all that nicotine replacement information in there as well. And I've got a couple of slides just to explain what brief behavioral interventions are. So it was created through the substance abuse industry that was about anyone that advises other people can use this. So it's not like a counseling session. You're not doing psychological work with your patients. You're trying to figure out what's this particular problem that we want to sort out, such as he's smoking, and we're going to look at how we help them to either reduce or stop that particular activity. So we're asking our patient to change something. And so it's very much based on our understanding of change. The components, and I'll go quickly through them here. We've already done them with the 6 years last week, very important for the 6 years, is that the way that your BBI is structured is around giving feedback. You're going to actually basically just give feedback on your student on why this is a problem. You're going to make your patient responsible for what's happening. You're going to be the one giving them advice to stop. So it is quite directed by you, but you're going to give them options and help your patient choose what they want to do. The way we do this is very empathic and respectful towards our patient, and we really want to build the self-efficacy of the patient to actually get the job done. So that's the frames BBI components. A key part of doing any brief behavioral intervention is understanding how ready your patient is to change. I'm quite sure most of you has already come across the stages of change. This is what we go through, any of us go through, and we want to bring a new change into our body, into our lives. The first one is pre-contemplation. We at this stage are not contemplating a change. That might be because we don't think a change is necessary, but it might also be because it sounds like too much like hard work, or I don't care, I can smoke, or I'll never work. So you're not considering a change for whatever reason. And most of our interventions at this point is mostly about informing the patients about the potential risks and benefits. Then you might have somebody that goes, I really want to stop smoking, and I've been thinking about it, and I know I need to stop smoking. And so they've sort of already made the decision, but they haven't actually quite gone to doing anything about it. And you want to really start helping them visualize how much benefit this change is going to bring to motivate them to make that change. Then you've got they're now prepared and determined. They're going to do the job. And at this stage now is when you now actually give them the advice. This is your nicotine replacement plan. We're going to look at what a stop quitting plan looks like. So you're actually sitting down with the patient and you're working out what exactly they're going to do. And then that goes to your action phase. When they've actually quit, you're going to meet with them regularly to check how they're doing and to identify any things that might derail them. And then ideally, eventually, you want to get them to a maintenance phase where we're celebrating the fact that they've managed to stop. In the substance abuse world, they've got a 6th stage, which is the relapse stage. And then sort of people will end up going back through, if they relapse, especially if they relapse for a long time, then you're going back through the 5 stages of change. So the 5 A's is very much the WHO guide is built around the 5 A's. And we are going to be actually looking at that. There should be the students already have one, so just give out to the 6 years have got, so just give out to the interns and the MOs. And this is something that we can use for any intervention, so also for alcohol use, for poor adherence, et cetera, but we're going to look at now and apply it specifically around stopping smoking. So very important when you start off, you want to focus on, very important, you want to set the tone when you're starting off. So your first A, which stands for ask, is actually all about getting the patient to talk. And very important, you must always ask permission before you give a patient advice. We're quite often quite bad at doing that. We launch in with what we think they need to know. But actually, it's very important to check with them. Listen, I would like to speak to you about your smoking. That's very respectful. And it also makes the patient feel, okay, actually, yes, I will give you permission to now give me advice. Now you also want to figure out how much they smoke. You want to figure out those little habits. When do they smoke in the day? What kind of things, how early in the morning do they smoke? This will be a good time to do that Vargenstrom assessment to figure out how addicted they are. and you want to get an idea of what has happened in the past when they've tried to stop smoking. So you're going to pick their brains in the first one. In step number 2, which is the alert step, the WHO calls it the advice step, is where you're now going to start doing all the talking. And the WHO very nicely gives these three, that advice should be clear. So don't beat around the bush. You need to stop smoking. It needs to be strong. This is something that's important. But you really want to personalize your advice. So you don't want to come up with a whole lot of risks and benefits that, one day you can get cancer and this and this and that. You want to tie it to this particular person and why they need to stop smoking now in their lives. So if you want to bring up risks that might be relevant to them. So for women, it might affect your fertility. For men, it might cause impotence. If you want to, if they've got a health problem like asthma or COPD or issues like that, you want to link it directly to that. And social factors. So the effect it might have on their partner, on their children. This is where we're going to talk about money as well. And if it's not really possible to this person just smokes and there's nothing specifically you can tie it to, you can actually ask the person, what do you not like about being a smoker? And you can then use that as a foundation to build your argument. Under the alert advice, you're going to talk about the risks, and we all know the risks. So I'm not going to even spend time on that. And again, you want to personalize it as much as possible, but actually you don't want to have a whole big scaredy cats thing. You want to spend most of your time actually talking about the health benefits. And the WHO has got a lovely fact sheet that we must actually make available in the department, which can show people how quickly your body starts to recover from what you are doing in it. So already within 20 minutes, your blood pressure is going to drop. Within 12 hours, your carbon monoxide level is going to drop. You're going to start getting your puff back within 12 weeks. You can see that at 1 year, your risk of coronary heart disease is about half that of a smoker. By 5 years, your stroke risk is reduced to that of a non-smoker 5 to 15 years after quitting. So these are very sort of amazing images you can give your patient of how their health is improving just by not smoking. They've also shown in terms of in comparison what happens with people who have continued smoking versus those who's managed to stop. So if you stop at the age of 30, you can add an extra 10 years to your life. Stop at the age of 40, you can gain an extra 9 years. You can see by 60, if you stop, you're not gaining massive amounts of years, but it can have quite a rapid benefit on particular risks like COPD and heart attack if you are stopping smoking. Very important is also that advice of how secondhand smoke affects children, for example, and talking about the effects on fertility and pregnancy. Another nice little thing is also in the WHO thing is actually working them out how much money they save if you quit. So figuring out, even if they're only smoking 10 cigarettes a day, that's already 500 Rand a month. Usually people who smoke less, actually people who have less money. So they're trying to restrict the amount of cigarettes they can actually buy. And so for them actually having to see that number can also be a helpful motivator. And what would you rather do with that money? Your third step is now being able to assess, okay, I've given my patient lots of information. Now I want to know how likely is it they're going to change and make this change. And this is from motivational interviewing, where we try and establish how somebody is ready for change. And your first question is you're basically trying to figure out is how motivated they are and how able they are to stop. So your first question is, how important is it for you to stop smoking? Would you like to be a non-smoker? How much would you like to be a non-smoker? And you can use your scale from 1 to 10. And how able are you to stop smoking? So somebody might say, oh, I really want to stop, but actually I've tried, there's no ways, I just don't have what it takes or whatever. So this already gives you an idea of where am I patient within their 5 phases. Sometimes you might have a scenario, even after all your talking, where your patient is actually not ready to change. They're like, no, doc, I just can't do it. And the WHO calls us the 5 R's of 5 particular things you want to look at that you're going to use to have a discussion for somebody who's very resistant to change. So first, again, relevance, to make it very personally relevant. That should already been in your discussion, but to emphasize what is the relevance for you to now stop smoking. And now when you want to talk about the risks or the rewards, you're asking the patient. I want the patient to identify what is the negative consequences of their smoking. And you want the patient to identify what is the potential benefits of stopping. And these are, of course, patients who are not motivated at all. You might have patients who are motivated but are not able to make the change, and then you want to help them identify the barriers to quitting. What was the roadblocks? What's happened in the past? Once you've done your first 4 hours, the 5th hour is actually repeating their assessment of readiness to quit and seeing if you've able to move them on to the next step. So step number 4 is now assisting them to actually stopping smoking. And you're going to set goals and develop a quit plan. So there's something called the STAR. It's also from the WHO, where your S stands for you set a quit date. What are you going to do? You tell your friends, family, and co-workers. So the patient must set the date. Then they must inform everybody that on that day, I'm stopping smoking, get everybody's support. You want to anticipate challenges, and this is where you can help your patient by looking at, for example, using NRT or using another product to deal with the cravings, thinking about the habits, thinking about who they're hanging out with. And then the last step is before you stop smoking is to make sure there are no cigarettes or no tobacco products anywhere in easy reach in your home or in your environment. When we're assisting our patients, we're going to help them do their quit plan. And then you want to sit with them and really start thinking about what might the triggers or risk situations. And they give some very nice cognitive and behavioral coping techniques. I'll show a couple of those just now. And very important, this is the point where you now make a plan with your NRT and give them written information on that nicotine replacement. The cognitive behavioral things that's in the WHO thing is that we can also treat some of these withdrawal symptoms with simple home remedies or even a bit of Brufen if they get headaches, or eating regularly, hydrating well, exercising, if they're getting a bit of a cough or irritation, steaming. So finding ways to actually deal with the symptoms of the withdrawal. To deal with smoking cravings, if you're not going to do NRT, the idea is that they call it the 4 Ds. Delay, set a time limit before you go. So the patient decides, okay, I will not smoke less than 2 hours apart. So if I've had my cigarette at 8, I will not smoke by 10 o'clock. That's just a rule. Then when you get to 10 o'clock and you're struggling, then you take 10 deep breaths, try and see if the urge passes. If that's still not working, you go and drink water. And if that's still not working, you go and do something else. It's fairly simple. The increased appetite is something to think about early on. So if people are going to end up snacking when they're craving, to figure out what they're going to snack on and just to preempt that before they end up starting to balloon once they go off their cigarettes. To keep on focusing on these positive thoughts and ideas of what they're trying to reach, because otherwise they start ruminating when they're in withdrawal too much on about how horrible it all is. Quite often people get very restless, and actually building exercise into the program can help. And of course, your practices like mindfulness and meditation to help for the anxiety. Lastly, you want to arrange a follow-up and monitoring. If possible, it's nice if they see the same healthcare provider. You want to build a relationship with the patient. You're going to write down those goals. If they've set a stop-quit date, you want to see them within the first week of busy stopping quitting to see how they're going and if the NRT is doing the trick. And then you want to see them again 1 month after that date they've set to quit. If they've managed to quit, obviously lots of positive reinforcement and focus on managing risk. If they did not manage, then we're still going to positively reinforce that they tried, and we're going to look at that as a learning opportunity to see how we're going to manage the next time around to stop quitting. So in summary, we need to actively actually identify people who smoke or vape. I think we're quite good at asking about smoking, but I quite often wonder if we don't specifically ask about vaping, whether people would just say no when you say they smoke. And especially our young people. You've got young people coming in for other things, is just checking if they are vaping and giving them a little bit of advice at that point of the great con. Use your 5 A's to do a brief intervention for your people who are smoking. Get very practical on that nicotine replacement therapy, and very important to follow up during that process. Quite often we give advice and then we don't actually check in on them to see how that process has gone. Thank you very much.